Section 1. Introduction and Etiology. Today we're going to begin by learning about SARS-CoV-2, the virus responsible for COVID-19. As a dental hygiene student, understanding this virus is important because dentistry involves close contact with the patient's mouth and respiratory tract, making infection control essential. SARS-CoV-2 stands for Severe Acute Respiratory Syndrome Coronavirus 2. It is classified as a novel beta coronavirus, meaning it was a newly identified coronavirus when it first appeared. The disease caused by this virus is called COVID-19. The virus was first identified in Wuhan, China in December 2019. Because it spread rapidly across multiple countries, it eventually became a global pandemic. Scientists compared the virus's genetic material to previous coronaviruses and found that SARS-CoV-2 shares about 79.6% of its genetic sequence with SARS-CoV, the virus responsible for the SARS outbreak between 2002 and 2003. Although they are related, SARS-CoV-2 spreads much more efficiently between people. Current evidence suggests the virus originated through zoonotic transmission. Zoonotic transmission means an infectious disease passes from animals to humans. Scientists believe bats were the original reservoir, with another intermediate animal possibly transmitting the virus to humans before widespread human-to-human transmission began. One of the most important structures on SARS-CoV-2 is its spike protein. These spike proteins give the virus its crown-like appearance under a microscope, which is why it is called a coronavirus. More importantly, the spike proteins allow the virus to attach to ACE2 receptors found on many human cells, especially cells lining the respiratory tract. Think of the spike protein as a key and the ACE2 receptor as a lock. Once the key fits into the lock, the virus gains entry into the cell and begins infection. This interaction between the spike protein and ACE2 receptor is one of the most important concepts to remember because it explains how infection begins. Key takeaway: SARS-CoV-2 is a novel beta coronavirus that causes COVID-19. Its spike proteins bind to ACE2 receptors on human cells, allowing the virus to enter and begin infection. Remember that the virus likely originated through zoonotic transmission and spread rapidly because of efficient human-to-human transmission. Active recall. Question 1. What does SARS-CoV-2 stand for? Answer: Severe Acute Respiratory Syndrome Coronavirus 2. Why? SARS-CoV-2 is the name of the virus, while COVID-19 is the disease it causes. Question 2. What receptor does SARS-CoV-2 use to enter human cells? Answer: A, CE2 receptor. Why? The viral spike protein binds to ACE2 receptors, allowing the virus to enter respiratory epithelial cells. Question 3. What is zoonotic transmission? Answer: Transmission of a disease from animals to humans. Why? Evidence suggests SARS-CoV-2 originated in animals before infecting humans. Section 2. Standard precautions versus transmission-based precautions. Now that we understand what the virus is, let's discuss how dental professionals protect themselves and their patients. The first level of protection is called standard precautions. These are infection control practices that are used with every single patient, regardless of whether they appear sick. The idea is to assume that anyone could potentially carry an infectious disease. Standard precautions include proper hand hygiene before and after every patient, wearing basic personal protective equipment such as gloves, masks, and protective eyewear, and routinely cleaning and disinfecting environmental surfaces. Sometimes, however, standard precautions are not enough. When a patient has a known or suspected infectious disease spread through specific routes, healthcare providers use transmission-based precautions. These precautions add another layer of protection. Examples include wearing N95 respirators instead of regular surgical masks, using isolation gowns, screening patients before treatment, isolating infectious patients when appropriate, and improving environmental controls through HEPA filtration and negative pressure rooms. For SARS-CoV-2, dental professionals use both standard precautions and transmission-based precautions. This is especially important during aerosol-generating procedures because aerosols can remain suspended in the air and increase the risk of viral transmission. Remember it this way: Standard precautions are used for everyone. Transmission-based precautions are added when additional protection is needed because of a known or suspected infectious disease. Key takeaway. Standard precautions are used for every patient and include hand hygiene, basic PPE, and environmental disinfection. Transmission-based precautions provide additional protection, such as N95 respirators and enhanced ventilation, when treating patients with diseases like COVID-19. Active recall. Question 1. Are standard precautions used only for patients with infectious diseases? Answer: no. Why? Standard precautions are used for every patient regardless of infection status. Question 2. Which type of mask is recommended during aerosol-generating procedures involving SARS-CoV-2? Answer: N95 respirator. Why? N95 respirators provide a higher level of respiratory protection against airborne particles than surgical masks. Question 3. Give 2 examples of standard precautions. Answer: hand hygiene and wearing gloves. Why? These are routine infection control measures used with every patient. Section 3. Airborne transmission and droplet versus airborne transmission. Now let's examine how SARS-CoV-2 spreads, especially in the dental setting. During many dental procedures, SARS-CoV-2 can become aerosolized. Aerosols are tiny particles smaller than 5 micrometers. Because they are so small, they can remain suspended in the air for long periods and travel farther than 1 meter. Several common dental procedures produce aerosols. These include ultrasonic scaling, using a high-speed handpiece, air polishing, and operating the air-water syringe. Because these procedures generate aerosols, they carry a higher risk of airborne transmission. To reduce this risk, dental offices use multiple mitigation strategies. High-volume evacuation removes aerosols close to their source. HEPA filtration removes airborne particles from the environment. Good ventilation increases air exchanges within the operatory. And N95 respirators protect clinicians from inhaling infectious particles. It's also important to understand the difference between droplet transmission and airborne transmission. Droplet transmission involves particles larger than 5 micrometers. These droplets are relatively heavy, fall quickly because of gravity, and usually travel less than 1 to 2 meters. Infection occurs when droplets land directly on another person's eyes, nose, or mouth. Surgical masks, face shields, and physical barriers are effective at preventing droplet transmission. Airborne transmission involves particles smaller than 5 micrometers. These tiny particles can remain suspended in the air for hours, travel farther than 2 meters, and infect someone even after the infected individual has left the room. This is why airborne transmission is such a concern during aerosol-generating dental procedures. One important point is that dental procedures can produce both droplets and aerosols. Ultrasonic instruments may even break larger droplets into much smaller aerosol particles, increasing the risk of airborne spread. When remembering the difference, think of it this way. Large droplets fall, tiny aerosols float. Key takeaway. Droplets are larger than 5 micrometers and fall quickly, while aerosols are smaller than 5 micrometers and can remain airborne for hours. Because dentistry frequently produces aerosols, enhanced ventilation, high-volume evacuation, and N95 respirators are critical for infection control. Active recall. Question 1. What particle size defines an aerosol? Answer: less than 5 micrometers. Why? Aerosols smaller than 5 micrometers remain suspended in the air much longer than larger droplets. Question 2. Name 2 common aerosol-generating procedures in dentistry. Answer: ultrasonic scaling and using a high-speed handpiece. Why? Both procedures produce fine aerosols that increase airborne transmission risk. Question 3. Which transmission route allows infection even after an infected person has left the room? Answer: airborne transmission. Why? Aerosols remain suspended in the air and can be inhaled long after they are produced. That concludes Lecture 1. In Lecture 2, we'll cover what happens after the virus enters the body, including its pathogenesis, signs and symptoms, mortality, comorbidities, and the latest treatments. Lecture 2, Disease Process and Clinical Management, Slides 6 to 10. Section 1, Pathogenesis of COVID-19. Now that you understand how SARS-CoV-2 spreads, let's look at what happens after the virus enters the body. This process is called pathogenesis, which simply means the development and progression of disease. The infection begins when SARS-CoV-2 enters through the nasal, oral, or conjunctival mucosa. The conjunctiva is the thin membrane covering the eye. Once inside the body, the virus uses its spike proteins to bind to ACE2 receptors on respiratory epithelial cells. Remember, the spike protein acts like a key, and the ACE2 receptor acts like the lock. After entering the cell, the virus releases its RNA into the host cell. Viral RNA contains the genetic instructions needed to make new viruses. Instead of functioning normally, the infected cell is hijacked and forced to produce viral proteins and assemble thousands of new virus particles. As this process continues, the infected cell is damaged and eventually destroyed, releasing newly formed viruses that infect neighboring cells. As the infection spreads, the immune system recognizes the virus and responds by releasing signaling proteins called cytokines. Cytokines help coordinate the body's immune response by attracting immune cells to fight the infection. In most people, this immune response helps eliminate the virus. However, in severe cases, the immune system overreacts and releases excessive amounts of cytokines, creating what is known as a cytokine storm. Instead of only attacking the virus, the overwhelming inflammatory response begins damaging the body's own tissues. The lungs are especially vulnerable. Severe inflammation causes fluid accumulation and damage to the air sacs, making oxygen exchange difficult. This condition is called acute respiratory distress syndrome, or ARDS. Patients with ARDS struggle to breathe because oxygen cannot efficiently move from the lungs into the bloodstream. If inflammation continues unchecked, multiple organs can become damaged, leading to multi-organ failure. Another important fact to remember is the incubation period. The incubation period is the time between exposure and the appearance of symptoms. For COVID-19, it generally ranges from 2 to 14 days. Peak viral shedding often occurs just before symptoms begin. Viral shedding refers to the release of virus particles that can infect other people. This explains why COVID-19 spread so efficiently, because people were often contagious before realizing they were sick. Key takeaway. COVID-19 begins when the virus binds to ACE2 receptors and enters respiratory cells. The virus hijacks the cell to replicate, while the immune response attempts to eliminate the infection. Severe disease results from excessive inflammation called a cytokine storm, which can lead to ARDS and multi-organ failure. Active recall. Question 1. What receptor does SARS-CoV-2 bind to before entering a cell? Answer: ACE2 receptor. Why? The viral spike protein attaches to ACE2 receptors, allowing the virus to enter respiratory epithelial cells. Question 2. What is a cytokine storm? Answer: an excessive immune response that causes widespread inflammation and tissue damage. Why? Instead of only attacking the virus, the immune system begins damaging healthy tissues. Question 3. What does ARDS stand for? Answer: acute respiratory distress syndrome. Why? ARDS is severe lung damage that decreases oxygen exchange and makes breathing difficult. Section 2. Current signs and symptoms. Now let's discuss how COVID-19 presents clinically. The most common symptoms include fever above 100.4 degrees Fahrenheit, or 38 degrees Celsius, dry cough, fatigue, and loss of taste or smell. Loss of taste and smell became one of the hallmark symptoms during the early stages of the pandemic because it occurred so frequently. Patients may also experience muscle or body aches, sore throat, diarrhea, and headache. These symptoms vary between individuals, which can sometimes make COVID-19 difficult to distinguish from other viral illnesses. More severe symptoms require immediate medical attention. These include shortness of breath, chest pain or pressure, confusion, and bluish lips or face. Bluish discoloration indicates inadequate oxygen levels and represents a medical emergency. One of the biggest challenges in controlling COVID-19 is that people do not always show symptoms. An asymptomatic person is infected but never develops symptoms. A pre-symptomatic person is infected and contagious before symptoms begin. Both asymptomatic and pre-symptomatic individuals can transmit the virus to others. This is particularly important in dentistry because a patient may appear healthy during screening while still being infectious. For this reason, dental professionals continue using standard precautions with every patient and implement additional precautions whenever appropriate. Key takeaway: COVID-19 symptoms range from mild respiratory illness to severe breathing problems. Fever, dry cough, fatigue, and loss of taste or smell are common, while asymptomatic and pre-symptomatic transmission make infection control especially important in dental practice. Active recall. Question 1. What are 4 common symptoms of COVID-19? Answer: fever, dry cough, fatigue, and loss of taste or smell. Why? These are among the most frequently reported symptoms. Question 2. Which symptom indicates severe disease requiring immediate attention? Answer: shortness of breath. Why? Difficulty breathing may indicate significant lung involvement and requires urgent evaluation. Question 3. Can asymptomatic individuals spread COVID-19? Answer: yes. Why? Even without symptoms, infected individuals can shed virus and infect others. Section 3. Mortality, comorbidities, and current treatment. Let's finish this lecture by discussing who is at greatest risk and how COVID-19 is treated today. The case fatality rate, or CFR, is the percentage of diagnosed individuals who die from a disease. For COVID-19, the estimated case fatality rate has generally ranged from about 0.8 to 3%, depending on the region, patient population, and access to healthcare. Older adults, particularly those over 70 years of age, have experienced the highest mortality rates. By the middle of 2025, the United States had recorded more than 1.1 million COVID-19-related deaths. Fortunately, widespread vaccination campaigns and improved treatment strategies have significantly reduced mortality compared with the early stages of the pandemic. Another major factor affecting disease severity is the presence of comorbidities. A comorbidity is an underlying medical condition that exists before a patient develops another disease. Approximately 87% of hospitalized COVID-19 patients have at least one underlying condition. About 94% of patients admitted to intensive care units have one or more comorbidities, and roughly 60% of COVID-19 deaths are associated with 3 or more underlying medical conditions. High-risk conditions include diabetes mellitus, hypertension, cardiovascular disease, obesity with a body mass index of 30 or greater, chronic respiratory disease, chronic kidney disease, immunocompromised states, and active cancer. Researchers have also found growing evidence that oral health may influence COVID-19 severity. Patients with periodontal disease may experience greater inflammation, potentially worsening systemic inflammatory responses. Treatment has also advanced considerably since the pandemic began. The antiviral medication Paxlovid, which contains nirmatrelvir and ritonavir, in high-risk patients. Remdesivir shortens recovery time in hospitalized patients, while molnupiravir provides another oral antiviral option with moderate effectiveness. Some treatments work by modifying the immune response rather than directly attacking the virus. Monoclonal antibodies have been updated as variants emerge. Dexamethasone reduces mortality in patients requiring supplemental oxygen by decreasing excessive inflammation. IL-6 inhibitors help manage cytokine storms in severely ill patients. Current research continues to investigate long COVID, universal coronavirus vaccines, nasal spray vaccines that strengthen mucosal immunity, and the relationship between oral health and systemic disease. Key takeaway: advanced age and multiple comorbidities greatly increase the risk of severe COVID-19. Modern treatment combines antiviral medications that reduce viral replication with immune-based therapies that control excessive inflammation, leading to significantly improved patient outcomes. Active recall. Question 1. What is a comorbidity? Answer: an underlying medical condition present before another disease develops. Why? Conditions such as diabetes or hypertension increase the risk of severe COVID-19. Question 2. Which antiviral medication can reduce hospitalization by about 89% when given early? Answer: Paxlovid. Why? Early treatment reduces viral replication before severe disease develops. Question 3. What medication reduces mortality in patients requiring supplemental oxygen by decreasing inflammation? Answer: dexamethasone. Why? It suppresses excessive immune responses that contribute to severe lung damage. That concludes Lecture 2. In Lecture 3, we'll cover SARS-CoV-2 variants, diagnostic testing, wastewater surveillance, vaccines, and the key prevention strategies every dental hygienist should know. Lecture 3, Variants, Diagnosis, Prevention, and Public Health. Slides 11 to 15. Section 1, SARS-CoV-2 variants. Now that we've covered how COVID-19 develops and how it is treated, let's discuss one reason the pandemic changed over time: viral variants. A variant is a version of a virus that has accumulated genetic mutations. Viruses naturally mutate as they replicate. Most mutations have little effect, but some make the virus spread more easily, evade immunity, or become more severe. One of the first major variants was Alpha, also known as B. It was first identified in the United Kingdom in September 2020. Alpha was approximately 50% more transmissible than the original strain because it contained the N501Y mutation, which increased the spike protein's ability to bind to ACE2 receptors. Next came the Delta variant, or B, first identified in India in October 2020. Delta spread about 60% more easily than Alpha and produced higher viral loads, meaning infected individuals carried more virus and were generally more contagious. Delta was also associated with more severe disease. Then came Omicron, or B, identified in South Africa in November 2021. Omicron spread much faster than previous variants because it had numerous mutations that allowed it to partially escape existing immunity from previous infections and vaccinations. It later evolved into several sublineages, including BA through BA. More recently, variants such as EG, also called Eris, and JN, became dominant between 2023 and 2025. These variants demonstrated increased transmissibility and better immune evasion, meaning they could infect people who already had some immunity. Fortunately, they generally caused milder illness than earlier variants, but resulted in more reinfections. Organizations such as the CDC and WHO continuously monitor new variants. They classify them as variants of interest, or VOIs, and variants of concern, or VOCs, based on characteristics like transmissibility, disease severity, and immune escape. The important concept is that viruses continue evolving, so public health recommendations and vaccines must also evolve. Key takeaway: SARS-CoV-2 constantly mutates, creating new variants that may spread more easily or evade immunity. The Alpha, Delta, Omicron, and more recent variants demonstrate how viral evolution can change the course of a pandemic, requiring continuous monitoring by the CDC and WHO. Active recall. Question 1. Which variant was associated with significantly higher viral loads and increased disease severity? Answer: Delta. Why? Delta produced higher viral loads and generally caused more severe illness than earlier variants. Question 2. Which variant showed significant immune escape and produced multiple sublineages such as BA through BA? Answer: Omicron. Why? Omicron accumulated numerous mutations that allowed it to partially evade existing immunity. Question 3. What does VOC stand for? Answer: Variant of Concern. Why? Variants of concern have characteristics such as increased transmissibility, greater severity, or immune escape. Section 2. Testing methods and wastewater surveillance. Let's move on to diagnosis and community monitoring. The gold standard for diagnosing COVID-19 is the RT-PCR test. RT-PCR stands for Reverse Transcription Polymerase Chain Reaction. This test detects viral RNA from samples collected with nasopharyngeal or oral swabs. Because it directly detects the virus's genetic material, RT-PCR has a sensitivity of approximately 95 to 98%. The main disadvantage is that results usually take 1 to 3 days. Rapid antigen tests detect viral proteins instead of viral RNA. They provide results in only 15 to 30 minutes, making them useful for quick screening. However, they are less sensitive, around 70 to 90%, meaning false negative results occur more frequently than with RT-PCR. Antibody tests are different because they do not detect the virus itself. Instead, they detect antibodies produced by the immune system after infection or vaccination. These tests are useful for identifying previous infection but are not appropriate for diagnosing an active COVID-19 infection. Another fascinating public health tool is wastewater surveillance. Researchers discovered that infected individuals shed SARS-CoV-2 RNA in their feces. Scientists collect wastewater samples using methods such as the Moore swab, which places absorbent material into sewage systems to collect concentrated samples. The samples are processed by concentrating the material, extracting viral RNA, and performing RT-PCR testing. This allows scientists to estimate how much virus is circulating within an entire community. One of the biggest advantages of wastewater surveillance is that viral RNA often appears 4 to 7 days before clinical cases begin increasing. This provides an early warning system that allows public health officials to increase testing, prepare hospitals, and allocate resources before outbreaks become widespread. Wastewater surveillance is also cost-effective because it monitors an entire community, including individuals who may never seek medical testing. Key takeaway: RT-PCR remains the gold standard for diagnosing active COVID-19 infection because it detects viral RNA with high accuracy. Wastewater surveillance provides an early warning system by detecting viral RNA several days before clinical cases begin increasing. Active recall. Question 1. Which COVID-19 test is considered the gold standard? Answer: RT-PCR. Why? It directly detects viral RNA and has the highest sensitivity. Question 2. Why are antibody tests not useful for diagnosing acute COVID-19? Answer: they detect past immune responses rather than current infection. Why? Antibodies develop after infection or vaccination and do not indicate active viral replication. Question 3. How many days before clinical cases can wastewater surveillance detect increasing viral activity? Answer: about 4 to 7 days. Why? Viral RNA is shed into wastewater before many infected individuals develop symptoms or seek testing. Section 3. Vaccines and Prevention. We'll finish this lecture with the most important topic for dental professionals: prevention. COVID-19 vaccines are updated regularly to match circulating variants, especially to protect individuals at higher risk for severe disease. The most common vaccines are mRNA vaccines, including Pfizer-BioNTech and Moderna. These vaccines do not contain live virus. Instead, they deliver messenger RNA that instructs our cells to temporarily produce harmless pieces of the SARS-CoV-2 spike protein. Once these spike protein pieces are produced, the immune system recognizes them as foreign and creates antibodies and memory immune cells. If the real virus later enters the body, the immune system can respond much more quickly. Another vaccine type is the protein subunit vaccine, such as Novavax. Instead of using messenger RNA, these vaccines contain purified pieces of viral proteins combined with adjuvants, substances that strengthen the immune response. Because they contain only protein fragments, they cannot cause COVID-19. Vaccination has significantly reduced severe illness, hospitalization, and death. During the early stages of the pandemic, healthcare workers, including dental professionals, were prioritized because they faced frequent exposure to potentially infectious patients. Vaccination alone is not enough, however. Infection control remains essential in every dental office. Hand hygiene is still one of the most effective methods of preventing disease transmission. Hands should be washed with soap and water for at least 20 seconds, or cleaned with an alcohol-based hand sanitizer containing more than 60% alcohol before and after patient contact. Respiratory protection is equally important. During aerosol-generating procedures, dental professionals should wear properly fitted N95 or KN95 respirators. Fit testing and seal checks help ensure adequate protection, and masks should be replaced if damaged, soiled, or difficult to breathe through. Ventilation also plays a major role. Dental operatories should maintain more than 6 air changes per hour whenever possible. Additional protection includes HEPA filtration, directional airflow, operatory fallow time between patients, and, in some settings, UVC air disinfection. Surface disinfection remains another cornerstone of infection control. EPA-approved disinfectants should be used with the correct contact time, paying particular attention to high-touch surfaces and minimizing unnecessary equipment within the operatory. Finally, patient screening remains an important first step. Screening for symptoms and recent exposures helps reduce the risk of transmission, while following current CDC and OSHA guidance ensures that infection control practices remain consistent with the latest scientific evidence. Key takeaway: vaccination, proper PPE, hand hygiene, ventilation, environmental disinfection, and patient screening work together to reduce COVID-19 transmission in dental settings. No single intervention is sufficient by itself, but combining these strategies provides the highest level of protection for both patients and dental professionals. Active recall. Question 1. How do mRNA vaccines work? Answer: they instruct cells to produce harmless spike protein pieces that trigger an immune response. Why? The immune system learns to recognize the spike protein before exposure to the actual virus. Question 2. How long should hands be washed with soap and water? Answer: at least 20 seconds. Why? Proper hand washing effectively removes microorganisms and reduces disease transmission. Question 3. During aerosol-generating dental procedures, which respirator is recommended? Answer: an N95 or KN95 respirator. Why? These respirators filter airborne particles much more effectively than standard surgical masks. That concludes the SARS-CoV-2 and COVID-19 lecture series. Across these 3 lectures, you've covered the virus's origin, transmission, pathogenesis, clinical presentation, treatment, variants, testing, vaccination, and the infection control measures that are essential for safe dental practice.